Okay. Do I really need a microphone?
I think it's for the recording.
Oh, okay, yes, I do need a microphone then. I'm Dr. David Mrad, and I am a forensic psychologist. So I have been here at Forest now for over 5 years, but I spent 25 years in prison. Actually, I got to go home every night, but I worked for the federal prison system for 25 years, and during most of that time, I worked as a forensic psychologist. And what I mean by that is all of that time I was a correctional psychologist. I worked in a correctional institution, but there are many people who work in corrections, and what they do is very much like what psychologists do out in the community, except that community is a closed, gated community, and so it's different in that sense. Forensic psychology is a little more specific than that. It's a subfield of psychology that applies psychological knowledge, psychological science to decision-making by either legal or administrative authorities. So, for instance, the kind of forensic psychology I did was criminal forensic psychology. So I would work with courts and answer questions like, is this person competent to stand trial? Or was this person responsible for their actions at the time of a crime they committed? Or would this person be dangerous if they were released in the community, or if they were a capital defendant and they were going to be sentenced, would they be dangerous and should they be executed? So there are a number of questions that we would address that would help legal decision makers decide. Questions that involved some psychological function. There's also an area that I don't do, which is civil forensic psychology, and they answer questions for courts and administrative bodies, like, is somebody disabled, or does somebody have a personal injury, an emotional injury that was caused by some particular event, or make recommendations to courts about child custody decisions. So the field of forensic psychology is fairly broad and involves lots of different areas, but in all of those cases, it involves helping somebody else, using psychology really to help some other decision maker make that decision. In order to do that, I don't know of any situation in forensic psychology that doesn't require a doctor. It usually requires a doctorate and licensure, or in my case, I'll also have board certification in forensic psychology, which isn't necessarily required, but is not a bad thing to have when you're going into court. That's probably as much as I need to say. And I'll, Kristina?
Stand up. We decided that already. So my name is Dr. Kristina Brown. I'm a licensed marital and family therapist. I'm also the program director of our marriage and family therapy programs here at Forest. I've been at Forest for about over 7 years. I've also been a practicing licensed marital and family therapist for 18 years in New York before this, and California before that. I have a very different specialty than Dr. Mrad. So I work with couples and families. About 50% of my client contact over the past 18 years has been with couples and families, and the other half is with individuals. So even though I'm systemically trained, which means I look at the systems in which people interact and the relationships they have, I do work with individuals, but typically they'll come to me with relationship issues. So for example, and I do have to step out a little bit early because I have a 7 o'clock client at my private practice. I work with a lot of couples who are struggling with infidelity, communication issues. An area of specialty of mine is chronic illness or terminal or acute illnesses, when couples or family systems have experiences like that, and it changes the nature of what's going on with them. I work with a lot of families who are struggling parenting or coming together, bringing a new system. Often I'll have second marriages where they've blended families and are struggling with how to parent the system. And then I'll have a lot of individuals who'll come in, either they're trying to decide between their spouse and their girlfriend, or they're trying to decide what they want to do in their relationship, girlfriend or boyfriend to be fair. Where they're trying to decide what to do in with their relationship and moving forward, or they want to be better in their relationships with family members or loved ones or friends. And that's kind of it. Marriage and family therapy, you can practice at a master's level with a license. We also have a postgraduate degree certificate, so for people who are already licensed as an LPC or a psychologist and they'd like to get some specialized training in marriage and family therapy, we do have a certificate that our students can do. I went on and got my Ph.D. because I wanted to go into academia and do research, and so that was a different, but across all 50 states you can practice with a master's level license. So.
I am Dr. Michele Williams. I am a board-certified behavior analyst doctoral, or a BCBA-D. I'm the program director of the Applied Behavior Analysis programs, and we have a master's and 2 certificate programs. My background's a lot different from theirs too. I went to West Virginia University for my master's and my PhD in experimental analysis of behavior, which means I spent all of my time in labs working with rats and pigeons and fish, so even different than who they have worked with. And that was to study the basic principles of behavior. If you ever heard of B.F. Skinner or heard of the operant chamber or the Skinner box or operant conditioning, that's the kind of research that I did. And also I had planned to kind of continue doing that for the rest of my career, but it turned out I really love teaching. And when you're doing research primarily, you don't get to do very much teaching. So I went to a small college, actually went to do a postdoc fellowship in behavioral pharmacology, where I did the same kind of research with the addition of drugs with the rats. And then, not me, and then I went to a small college and took a teaching position. But the person that I took the teaching position from in Anderson, South Carolina, she was leaving that position. She and I had been to graduate school together and worked in the same lab, but she was leaving that position because she was going to start working with children with autism in applied behavior analysis. And that wasn't a part of our training specifically. The basic principles are the same, but we were trained in the basic principles in the lab. So she had gone to California, to UCLA, to study with Ivar Lovaas, who basically kind of invented the use of this therapy, the application of this therapy with children with autism. And she was opening her own clinic. So I thought, well, that's very interesting because we have the same background, and I had never thought about doing anything like that. So I watched what she was doing and kind of started working with some of her clients, and I thought, well, look, it does work the same. The stuff I learned does apply to people, and I knew it did, but it was really gratifying to see that I could change the environment that the child was in and change how people around that child responded to their behavior, and that would change the behavior of the child. And so I was intrigued and kind of hooked, and so I began working. I left the academic job and began working as a consulting behavior analyst, and I moved back to Springfield, and I started seeing clients all through Missouri, designing in-home ABA programs and also in school programs for children with autism. But I missed teaching, and so I went back to it and ended up here and started the Applied Behavior Analysis program in the fall of 2011. And basically, behavior analysis has changed a lot since I first started in graduate school, and applied behavior analysis is much more popular, it's much more well known now, and it's actually something that's a lot more accessible to more people, although not nearly enough. There is a tremendous need for behavior analysts, and so basically we can't get enough people trained to fill the need fast enough all over the country. The jobs are available, and So what's happening is that people are getting masters in psychology or behavior analysis or education. and sitting for a certification exam to be a board certified behavior analyst. If you have a master's degree in one of those fields, you can sit for that BCBA exam. If you have a bachelor's degree and you get specific training in behavior analysis, you can get a board certified assistant behavior analyst certification. So those are the two certificate programs we offer too. If you already have your master's, you can take the BCBA program and get the required education and training, the supervision required to sit for the BCBA exam, or the same for the BCABA if you already have your bachelor's and you don't want to continue. Or if you have your bachelor's and you want to get a master's, you can do that and you get all of your certification requirements met on your way to the degree. But basically, like you were saying, a master's is all that's required for practicing, and frankly, at a bachelor's level, there's a tremendous need for BCABAs as well. So bachelor's or master's, you can find work and apply behavior analysis.
Wow, it's my turn. It's always weird hearing your own voice over the speaker system. My name is...
Sounds weird.
Yeah. Thank you. My name is Estevan. I'm a doctor, I swear. I'm a behavioral neuroscientist in a broad sense. Behavioral neuroscience is understanding, or is a field of neuroscience that attempts to relate the physiological and biological processes that contribute to behavior. My specific specialty is neuropharmacology. So my research experience has been studying how drugs affect these biological systems and then in turn influence individuals' behavior. Normally this is not something that would necessarily be directly related to clinical work. However, there is that indirect relationship between behavioral neuroscience and clinical neuropsychology. And when we talk about clinical neuropsychology, we're talking about a group of specialists who assess and treat neurobehavioral problems stemming from central nervous system dysfunction. So the kind of work that I do lays the groundwork for the work that clinical neuropsychologists do and that neurologists do in terms of looking at central nervous system dysfunction and then both assessing and treating central nervous system dysfunction. This is kind of a weird path, because when you talk about behavioral neuroscience, you automatically assume biology. And yeah, I had a bio major, but I was actually a psychology. I had a bio minor, but I was a psychology major. I was a psychology major because my interest really was behavior oriented. And so when we talk neuroscience, you can go Ph.D., you can go M.D. I would very much recommend that if your emphasis is going beyond the reductionism, going beyond just breaking down the central nervous system into its little convenient component parts, and you want to look at the whole picture and how this influences behavior, because really, if you are studying the brain, your goal is to study behavior ultimately, because that's the brain's whole function, right? There is no behavior without the brain. You guys can all remember back to your intro to psych class and the case of Phineas Gage, right? We turn around, we talk about Phineas Gage and how damage to his brain profoundly affected behavior, right? So if it's one of those things where you can get into the field of neuroscience without necessarily having to do it via biology. There are subfields within psychology, like physiological psychology, which will effectively prepare you for the sort of behavioral neuroscience work, and then lays the groundwork for, if you decide to go clinical, right? If you decide to go clinical, you don't want to be stuck in a lab for the rest of your life, and you want to contribute to clinical work, or turn around and take this information that you know about how the nervous system works and apply it to these clinical cases. Then you can turn around and use this as the foundation for a clinical neuropsych degree, right? And with a clinical neuropsych degree, you can turn around and go off and get your doctorate either as a traditional Ph.D. or a Psy.D., and then turn around and get licensure, right? And get licensure, and then take all this knowledge you know about the biological underpinnings of behavior and use that to assess, right? To assess and treat instances where there is some sort of behavioral abnormality as a result of nervous system damage. you know, at least the path that I went with my Ph.D. with the intention to do research, right? And I never intended to teach, much less do anything clinical. I was going to get my Ph.D. and go work for biotech pharma and make $1 jillion. Yeah, I did that for a little while. And you realize you have to sell a bit of your soul to do that. And so that's not a whole lot of fun. But I did, as a graduate student, teach a couple classes and just fell in love with it. So that kind of started my path down academia. And then just, damn, I've been doing this for a long time. I think research-wise, I've been doing this for almost 20 years now, right? Almost 20 years. And eventually when we talk about, you know, as you go through a career, your interests, I don't want to say mature, they change, they grow. There's always some new question to ask, right? And I became very interested in clinical work, right? I became very interested in the application of the stuff that I was learning about the basic physiological processes that apply to behavior and focusing them on or applying them on these instances in which behavior was not normal, right? In which behavior was not normal. And that brought me here, right? So I did my undergraduate degree, I did my PhD, I did a postdoc, did a visiting professor position, I went into academia proper, left academia, went worked with biotech pharma, came back to academia because I missed teaching so much, right? And I like a complete soul. Missed teaching so much, and then became really interested within the last 3 years in clinical issues and had the opportunity to come here and work with this great group of people and this great population of students, and here I am.
Hello, my name is Dr. Robynne Lute, and I am fairly new to academia. I've been to Forest. I'm in my second year at Forest. I'll tell you a little bit about my path in terms of getting here, and then a little bit more about my role here. I attended graduate school at Baylor University in the Department of Psychology and Neuroscience. Did my internship and postdocs in hospital settings, so started to get familiarized with being in a medical environment and working in interdisciplinary settings. And my first post-degree job was actually in a primary care or community medical health center. So rather than working, you know, as I decided when I was 12 I was going to be a psychologist and sort of imagined myself in a dark room with people on the couch and me doing all sort of psychoanalytic things. And that evolved and changed very dramatically over time to where, you know, I was actually one of the only psychologists in a busy clinic, busy hospital with medical professionals, nurses, physicians, assistants, etc. So I loved that, absolutely loved that. I actually did some loan repayment during that time. If any of you are familiar with the loan repayment, it's a great place to work off lots and lots of your debt if you're willing to go into that primary care setting and learn a completely different way of being with clients and other providers than you would in a purely clinical sense. So I've done private practice where I saw 8 to 10 patients a day, or clients. We call them patients in the medical setting, so forgive me if I switch back and forth. We see 8 to 10 clients a day, made a whole bunch of money, but fairly isolative in some ways. You kind of meet with your client, go back to your office, meet with your client, go back to your office. So if you have a higher energy personality, if you like to work with other people, if you like to learn about different disciplines, working in an integrated setting might be a better choice for you. So when I was working in the private practice setting, I ended up adjunct teaching and decided I really liked to teach, and right about that same time I happened across a job announcement for the primary care program at Forest, and so it was a really nice amalgamation of all of the things that I like to do. So to be not only teaching in a clinical psych program, but then to have that primary care focus. So the way our tracks work in the Psy.D program is that you take all of your core courses, generally the first roughly 2 years, and then if you can either continue on as a generalist, or you can choose to be in one of our specialty programs, forensics, etc. So I coordinate the primary care psychology program, which the big focus for us is the idea that the body and the mind are not separate, and not just in a new agey sort of guru way, but when we get back to psychology being behavior, if you have depression, maybe you're not going to be as likely to take your medicine for diabetes and adhere to what you need to be doing to take care of yourself that way, and vice versa. If you have uncontrolled blood sugar, diabetes, you may get depression physiologically, which further complicates things. So, roughly 90% of people who go to a physician's office have absolutely no biomedical basis to the reason for their visit. So what that means is they have psychosocial concerns. They have stressors that present as backaches. They have marriage and family issues that cause them not to be able to sleep at night, etc. And so not only do we work, physicians have a very limited time with their patients, so they can say, you need to quit smoking. And then you as a psychologist behaviorist can come in and spend more time with that person and say, here's how you quit smoking, what's gotten in the way before, what are we going to do differently this time, and really make the physician's day, or I should say providers, because there's more than just physicians, make their days go a lot smoother, provide a lot more comprehensive care of any given individual, and provide more satisfaction for providers, for patients, etc. So you get exposed to a completely different culture in terms of medicine, like I said, working with different people, different terminology, but the basic ideas of changing behavior and, helping with mental health problems as well, but also behavioral health problems. So you're treating things like depression and anxiety, but you're also, as I mentioned, treating things like chronic illness and helping, those are the biggest killers these days are things that are cardiovascular disease, etc. They all have a behavioral component. So why are we killing ourselves, right? That's kind of what we're doing. So I don't know what else to say. Or I could say a lot more.
I think you guys did an excellent job. We've
Thank you.
given the audience quite a bit of information. Why don't we open it up to some questions? And I know some of you have places to be, so if you need to leave, that's fine too. But do you guys have any questions for our faculty members? Don't be shy. We're very informal here.
You have a question.
No, I just feel like everything you said is me. I'm telling you. Just let me come to you for a few days and you figure out what's wrong.
Well, and I want to emphasize, if you don't mind, I appreciate your interest. And as Dr. Williams said, one of the things she was mentioning is that there is a lot of need for ABA and a lot of job opportunities. The same is true for integrated care. This is the future of healthcare, and I'm sorry if it's not something you agree with, but with healthcare reform, with payment, reimbursement, everything is going to move towards integrated care. And even for people who remain clinical psychologists or forensic psychologists, etc., it's not that those are going to go away, it's just that all psychologists are going to be sort of reclassified as healthcare providers, not just so it's not just a separate thing anymore. So it's up and coming.
It occurred to me too when I was talking that I didn't give you the context for the kinds of settings that behavior analysts work in. And I talked about myself as a consulting behavior analyst working with children in their homes, doing early intensive behavioral intervention with children with autism. But behavior analysis is much broader than that. Behavior analysis actually can be applied to adults, typically developing adults or adults with developmental disabilities. Arc of the Ozarks is here in town, and they have a large applied behavior analysis department. So they work with their clients who live in supported living settings and group homes. You can work in education settings. Many schools are actually hiring behavior analysts as a regular part of their staff because children in special education, regardless of whether they're autistic or not, whatever the label, there are often interventions that can be designed and can be helpful for those individuals. And also, typical classroom management in educational settings is very beneficial whenever you take behavioral techniques for those kinds of situations and settings. So those are kind of the primary settings, school, or there are clinics too. Burrell has an autism clinic here in town, so behavior analysts work there, and the children come in to their day treatment program. I mentioned in-home, the school settings, the living settings for adults. So there's a wide variety of settings that people can work in for behavior analysis.
Michele, haven't you told me before that you work a lot with families?
Oh, yeah.
Kids a lot?
Yeah, not just working directly with the kids, but yeah, whenever, as you guys know, whenever you work in an educational setting, it's not just about changing the child. I mean, in fact, that's the least important part of it, honestly. It's about changing the behavior of the people interacting with the child. So all of the paraprofessionals that work there, or the teachers, kind of getting the behavioral strategies in place to effectively change that child's learning environment so that the behaviors they might have learned, the problem behaviors or so on that are interfering with more appropriate behavior, can be changed, can be removed, and so more appropriate behavior comes about and more progress can be made. So in home, it involves working with the family and people interacting with that child regularly.
So that's kind of a good segue. Actually, a couple weeks ago, my husband is a special education teacher here in Springfield, and he and I presented to the Missouri School Counselors Association up in Tantara and talked about working with families with children with special needs because it's a good marriage, pun intended, to really see that when someone comes in with an issue, you have to consider the context and the system in which they exist, because we can do all kinds of fancy stuff with someone in the room for 50 minutes a week, but if they go back to the same exact system from which they came, maintaining that change is near impossible. But I want to talk a little bit in the same vein that Dr. Williams did, sort of different contexts that marriage and family therapists or couple and family therapists work in. I have spent some time doing in-home family therapy, working with parents who were diagnosed typically with an Axis 2 disorder, so that would be a personality disorder, and help them to parent their children that they have and help them to get their children into services at schools that they're needed. I've also spent a lot of time in different private practices out of my own home, working as an independent contractor, working as part of a larger group. Some of our graduates, we have one of our graduates is actually a school therapist down at Joplin High School, which is different. She's not a guidance counselor, she's not a counselor there, she is the school therapist. It was a grant-funded position after the tornadoes to help kids sort of adjust, and she spends a lot of time actually doing risk assessments, kids who are suicidal, cutting, she spends a lot of her time doing that kind of thing. We have some of our graduates who are working, actually one of our graduates is the director of the Missouri Hotel. We're pretty proud of her. She did a practicum there and came into group after the first day and said she's going to take over the place and make it better, and she has. So we're pretty proud of that. She forgets she said that, but we remind her all the time. So there's some versatility to working in the field of marriage and family therapy. And then one of my interests, along with what Dr. Lute is talking about, is consider myself a medical family therapist. So one of my specialties, like I said, in my private practice is working with couples or families who are struggling with illness. Specifically, my interest is chronic illness, but I have had other presentations. And that's sort of in the same line what Dr. Lute is talking about. If you have that kid who's diagnosed with diabetes, that changes the whole family system. Mom and dad need to learn how to cook different meals, and brothers and sisters need to learn how to sort of support their sibling who is struggling with their diagnosis and make that a family change rather than that one person changing.
I think you can correct me if I'm wrong, but I see plenty of jobs for the master's level working in behavioral health, as many as I do see doctoral level.
Medical family therapy is a really quickly growing field. I mean, when I went to get my doctorate degree at Syracuse University in 2003, it wasn't even an option out there. And now there's about 12 different programs nationwide that offer masters, postgraduate degree certificates, and PhDs in specifically medical family therapy. So it is a quick growing field, and I believe that's in line with some of the things that Dr. Lute was talking about, where the future is headed around healthcare. So I can pass the mic to a specific person if you have a question for them, or.
I have a question, a question for all of you. If you had to give one piece of advice to someone who's following the same career path as you have, what would it be?
So for me, and then I'll pass it down, when I was in my bachelor's degree, I had a professor who I wanted their life. They taught, they saw clients, they had a really nice balance of different things that they were doing in their life, and I made an appointment with him and I said, how'd you get there? So basically that was the start for me, finding someone who was doing what I wanted to do, which is sort of why we're here. If we happen to be one of those people, please feel free to reach out to us, or if we don't necessarily represent what you envision yourself doing, maybe we have someone here that we can introduce you to, and then go for it. Love what you do.
That's a hard question, Lindsay, partly because I would say for me, and it sounded like for some others here, what we ended up doing was not what we intended to be doing. And so, so I guess the advice that I would give, for instance, the advice that I do give to our doctoral Psy.D students is that that getting a generalist education is very important. Even though I'm specifically in a forensic concentration, and I think a lot about forensic psychology, I would not encourage a student to spend too much time in that. In fact, I often encourage students to not focus too much on concentrations, because that's what they feel like they're going to do right now. I never had any intention to be a forensic psychologist. But that's sort of the path my life took. And so I think that it's important to have a good, basic, general education in a field like psychology, for instance, because that allows you to move into different areas when the opportunities and your interest change. And it also allows you to move into different areas, as like Dr. Lute was describing, when the realities of society and how practices work change.
I think my advice is kind of similar to Dr. Brown's. We're not, probably any of us are marriage and family therapists or behavior analysts from 9 to 5, and then we're not. So my advice is to immerse yourself in the field as soon as possible if you think this is the right field for you. You kids have the internet these days, so you can sign up for listservs, you can go to websites, you can check out the Behavior Analyst Certification Board, BACB.com, which has a host of resources for people who are planning to get certified. Get on listservs, get on Facebook and join groups with behavior analysis in the title, and just live it. Just kind of really immerse yourself in it, because there's so many opportunities to learn about the field when you're just going about your daily business, and it's very exciting, and we obviously all love what we do, and so we kind of can't just put it down when we get home. And I think that's good advice, because the sooner you can kind of become immersed in the field, the better it is, the more you learn.
Wow. Yeah, to reiterate that point that's been covered so well. When you take up a field like this, it's not a 9 to 5 job. You do this all the time. It is who you are. So to reiterate the idea that this is something that you should absolutely be interested in and enjoy, we cannot stress that enough. Yeah. Applying this to somebody who may or may not be interested in the field of neuro, if we're working on the assumption that you are interested in the field of neuro, I would say absolutely, and act as a counterpoint to Dr. Mrad, absolutely specialize in neuro, because neuro is one of those areas right now that we're just scratching the surface. There's so much to learn. We're talking about the most complicated piece of machinery that's ever been designed, and it wasn't actually even designed like in a conscious sense. Right? Right, not in a conscious sense. But I mean, we can make it was shaped by evolutionary processes, right? It was shaped by evolutionary processes. This is the most, there's still so much to learn about the field, right? And it can inform so many other areas of behavioral analysis. And if you are interested in neuro, 1, absolutely follow that path. 2, don't be intimidated by the bio. Don't be intimidated by the bio. It's not as complicated as its reputation suggests, right? It's in fact, if anything, I'd always thought that the neuro portion of analyzing behavior was always easier because it was concrete, right? It was something that you could see, that you could take apart, that you could measure. And not to say that you can't do that in other areas of psychology, but I mean, this is fairly black and white sort of setup, right? Action potentials, they either fire or they don't, right? It's pretty straightforward. Neural pathways, they either connect the way that they're supposed to or they don't. Drug interactions, right? These are all things that are easily quantifiable, and I think just people get unduly intimidated by the bio, and it's really not that bad. It really isn't. So if you have any interest in neuro, it's such a huge field. So many directions you can go, from the lab to the clinical setting and anywhere in between, private practice. Corporate business, right? And anything you could possibly want to do, you could do that with neuro. Just if you are gonna follow that path, think about what about neuro interests you and look for people who do that. Don't worry about programs. Don't worry about schools. Focus on people who do what you're interested in doing. And I don't think that necessarily has to fall to neuro so much as that. I mean, we could apply that to any field of psychology, right? I mean, graduate studies. Find people who are doing the kind of work that you are interested in. And don't apply to schools, don't apply to programs, apply to them, essentially. Apply to those people.
We don't require bio in our program.
I don't require stats, just saying.
We don't either.
Lindsay, I don't remember your question now. I mean, there were so many good answers. I think
A piece of advice that you would give to someone who's following a similar career path that you have.
Well, certainly, I think all of those were healthy and helpful answers, so I don't know that I have a lot to add, other than I would say be involved, and I mean that in a slightly different way than maybe just interacting with your professors or getting on listservs. So become members now of APA, become members now of MPA. Volunteer at places. Part of what you need to do and want to do is make yourself not only sort of well-rounded, to use that generic catchphrase, but also to put yourself in different kinds of situations where some of that experience you're going to learn if you volunteer 3 hours a week at the Boys and Girls Club. You're going to learn that you don't like kids, right? That's a helpful thing to know, okay? Go volunteer at the ER for 3 hours a week. You're going to find out that you don't like doctors. That's a helpful thing to know, okay? So the other piece of that is what's called networking. So while you're making informal connections, you're joining Psy.D, you're joining you're becoming a student member of APA, you're meeting other people. You get yourself to go to conferences, you're making connections, you're learning what other people are doing. And when we've all said, well, in many different ways, we may not have planned our career path out and then it went in that direction, it's those incidental kinds of encounters and conversations and interactions that you have that sort of open your mind up to other opportunities or to finding out what people need. So I just say be involved.
anybody have a specific MFT question? Because I have a client, a couple.
Can we watch?
Desperately needs me.
Can we watch?
We had amazing breakthroughs last week, so I'm excited for tonight's session, so. All right, thank you for having,
I'm sorry, I snuck in there at the very end. Question that I've got kind of is regarding like integrated care, but also MFT.
Okay, so I'll answer my part first.
Yes. In regards to like what the scene kind of looks like for an integrated situation with MFT addiction and that sort of thing. Do you see that?
I do. So actually, when I did my master's degree at the University of San Diego, and I did my practicum at a chemical dependency hospital, and I specifically chose that. It was not at all of interest to me to specialize in substance abuse or anything like that. But I also knew, working with couples and families, that they would come in with drugs and alcohol. It would be a big part of the issues that presented, and so I feel like I learned a pretty good baseline there. So definitely that's a part of it. Sometimes with couples and families it's not the presenting issue, but as I go through and I speak sort of the same language as Dr. Lute, a biopsychosocial spiritual sort of assessment of what's going on, the drugs and alcohol will definitely come up with that. But you know, for example, I worked with a mom a few years ago and she smoked pot every day and was not interested at all in what I had to say about quitting that. That was how she was surviving. She wanted to talk about the other things, and so part of my work was to try to get her to see that the other stuff was connected to the pot smoking, you know, that it wasn't necessarily alleviating that stuff, it was probably exacerbating it. And so that was part of our negotiations in developing a treatment plan, because we had different ideas about that. And then also at the same time, she was a pretty stressed out mom, and so I had to balance sort of those needs that she needed as well. But definitely, I don't specialize in substance abuse at all, but I have a good basic knowledge because it comes in with the majority of my families. So it's usually a doorknob. Oh, by the way, did you tell our therapist that you drink a bottle of wine every night? We call that doorknob therapy, when they've got their hand on the door and they tell you that bombshell that they should have started out the session with. So, all right, thank you for having me. Sorry.
Thank you, Dr.
Okay.
Okay, thank you.
Did you want me to say more about that?
You can go ahead, yeah.
Was the question about integrated care and substance abuse, and if those two sort of coincide, or?
Right.
Right, okay, so certainly with primary care psychology, you will absolutely see lots of substance use. Some of the reasons that the primary care setting is so helpful in terms of behavioral health change is that most people have relationships established with what we call a primary care provider, or their regular old doctor, their family doctor, and they in general are a lot more likely to present to that setting for any kind of problem. Even if they determine that it's substance abuse, they're more likely to go to their physician than to a mental health professional. So you also have the interaction of people becoming addicted to medications that are actually prescribed from the doctor. Those are actually some of our biggest addiction issues in the United States, especially with younger generations coming up, prescription medications and designer drugs, etc. Those aren't the ones provided by the doctors, but you see where I'm coming from. So for instance, some of the things, I've run entire substance abuse programs within the primary care setting. There's a medication called buprenorphine that's been used in Europe for years and years and years for pain management, but doesn't have the right FDA approval here in the United States, but it got FDA approval to be used. It's a partial opiate agonist, which means it's a helpful medicine to help people get off of heroin and other opiates. So we would work in an interdisciplinary team with a nurse, physician, etc., to prescribe this medication to help people come off of the drugs. And then I would do psychosocial groups, skill building groups, etc., to help get through that. There's a lot of chronic pain management in primary care, I mentioned that, so lots of stuff to do around that in terms of protocols. Sometimes you're writing contracts between the patient and the physician that the physician's not going to be rewriting more than one script every month for this or that or the other. So certainly there's a ton of it. Lots of people, that's the place they're going to show up to get substance abuse treatment, or where it might be detected anyway. Does that answer your question, or yeah? Okay.
Thank you.
Sure.
Any other questions from the audience?
Dr. Lute,
Yes.
and the primary care modality, do you see that only being a hospital or clinic setting, or is it also solo practice or?
It's interesting that you asked that. There's lots of different models. Okay, so one of the things that's a little bit confusing at times, and I'll get to your question. We have a specialty called health psychology, right? And health psychology definitely has that mind-body biopsychosocial component. But most people who go into health psychology either do research and or they work with a particular population. So they're really specialists in terms of, let's say, pediatric cancer, okay? The primary care psychology model that we're talking about, much more of a generalist model, so that if you're in a primary care setting, you're pretty much going to get anything that walks in the door, mental health, behavioral health. There are, however, for instance, I was in Washington, D.C. a few weeks ago at the Collaborative Family Healthcare Association presenting on telehealth and telemedicine. And what was my point? Darn it, I'm sorry, lost different models. Oh, and I met a gentleman who graduated from Forest in 1989, and he is up in Chicago with a private practice consulting to physicians' offices. So he does VHC model, but as a consultant where he goes out. So I think, the more with integrated healthcare we have, the more with the federal changes, the more options there are going to be, including the telehealth and the telemedicine. And so, yeah, it's not just one setting. But.
All right. Any other further questions? Okay. Well, the admissions department's going to stick around if you have admissions questions or if you want a tour. We also have a beautiful clinic, the Robert J. Murney Clinic, that we can give tours by appointment as well. We can work around your schedule. So we're so happy that you guys joined us tonight, and we can get you in touch with people's emails also if you think of questions later after today. So thank you for coming, and thank you so much to our faculty. Like I said before, they are the reason why people come to school here. They're experts, and students love learning from them. So thank you.
Thank you.